Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is how to mitigate risk while auditing for revenue integrity, sample design, interpreting results, and navigating compliance next steps. PYA is happy to present today's webinar on this important topic. I would like to introduce our presenters, Valerie Rock and Kimberly Campbell.
Good morning, all. Welcome to the webinar today. We're happy to join you with this important topic. So I want to give you a little bit of information about Kimberly and myself, and then we'll jump right in. So I'm Valerie Rock. I'm a principal with PYA. I've been with the firm over 22 years now, and I oversee all of our revenue integrity services and part of our compliance team. And Kimberly is a manager on our team and assists with that revenue integrity side of the house as well. So we are overseeing 20 to 30,000 records a year in audits, and we are doing these reviews on a regular basis. So we're happy to join you today and give you a little bit of our insights in regards to how to do this sampling and how to mitigate risk. So I'll jump over to our agenda. Basically, we'll look through the auditing and monitoring cycle and how that relates to the risk that you could potentially create yourself, which is the point here. We often are looking to audit and monitor for risk, but there is a way to create risk as you audit and monitor. So we want to talk about how that might happen and how you can mitigate that. Then we'll walk through statistical sampling for non-statisticians. No one's a statistician here today, so we want to make sure we're thinking through how we need to look at it from our perspective and how we need to leverage it out when we don't have the knowledge to do it. And we'll also make sure that everybody's up to speed on the 60-day rule, because there were changes to that last year, and we want to make sure everybody's up to speed on that. So let's talk about the auditing and monitoring cycle. As you're thinking about, you're getting into the new year, you're looking at your work plan. You might also already have some, hotline calls that are coming in, and you're needing to make sure you're working through your priorities and investigations, et cetera. So you're quickly moving into data analytics, audits, then working through root cause analysis and corrective action. So we're going to talk kind of all the way through that process and making sure that we're thinking through the potential risks there. So when we look at when we're going into an investigation and how we're stepping into that, we want to make sure that we're defining what we're really looking at. And so thinking through key questions about what you're really reviewing. Is it a certain area, a certain code? Is this a certain location? Is this a certain department, a certain provider? How are you narrowing that scope and really making sure you know what you're looking at? Also, just actually documenting that audit description, what that scope is, having that in a list so that 2 years from now what you did and how you came to those conclusions. Identifying the impact to departments, making sure that you know how many hours is it really going to take us to do this review? Do I have the capacity to do this review? And do I need to outsource it, insource it? What are my options here? And that everybody's aware of that as well. Making sure, again, that documentation is real key, preserving all of those notes and materials, making sure that you have those filed appropriately. Ultimately, we'll make sure that you can address those if ever, an external agency or party is looking at your review. when you're documenting your discussions and your analysis, making sure that your rationale is clear and that you can think through that again in the future, because your rationale may be really, logical to you today, but when you go, even a week from now, you may look back at it and say, I really don't even understand why I did that. So making sure you're working through that process and have a consistent process with that. Ensuring your stakeholders are really clear on what is going to occur, what your timeline is, when you're going to be back to them in regards to the results, et cetera, is also going to help you close that loop ultimately. Making sure that you have access to different locations, et cetera, and who you need to speak with, and what the variability is across all of those will help you define your scope as well. Then ensuring that you're meeting or looking for and reviewing the actual regulatory and legal requirements that are for the time period for the review that you're doing. So Kimberly, you want to start walking us through that data analytics piece?
Sure. Thanks, Valerie. And I do want to pause here for just a second. We're going to cover a lot here. There's a lot of material in here. Just a reminder that the notes are available for you all, and so you can download those now and afterwards just to have all those. But Valerie, before we jump in and cover this wide range of items, if compliance teams take one thing from today, what do you think that's going to be?
Yeah, I think. Right. I think that it really is that you can create your own risk when you're doing these audits. So making sure that you have the right people on the team. So we're going to show you how we have to think through this, and you're going to identify as we talk through this where you may have a gap on your team. And a lot of times that's really in the statistical area. When you're really getting into the weeds of identifying when you need to extrapolate and things like that, making sure that you have those right people in the discussions. A lot of that would also come up front too, right? Like making sure you have a plan to do this on a regular basis. So you may have a policy and procedure related to this as well.
Right. That's great. So yes, let's start with the available data. So internal versus external. With your internal data, you're looking for patterns. And then with the external data, you're watching enforcement trends. And so compliance teams should be asking themselves, does our internal data align with what regulators are focusing on right now? And if not, is it defensible? Is there a reason for that? So really let your internal data tell the story. And this list here are a few of the top items that we at PYA will hone in on when we evaluate data for an audit, especially if we're evaluating risk. The OIG, CMS, et cetera, as I'm sure you know, they look for these same things, right? Such as E&M bell curves, at-risk procedures. So we really want our use of the external guidance. We want to use it as a lens to view our internal data. And we'll get into more of this shortly, but Valerie, I know we day. So I do want to ask you in relation to this, if a health system's internal data looks clean, right, but then they have some outliers from an external perspective, how would you approach that?
Meaning that the payer has outliers or the external data looks like outliers?
Right. So as they're evaluating the external data and they're comparing that internally, they might see outliers. Is that something to always look into, or is it something that we've explained it before, we can kind of set it aside, or what's your experience on that?
Yeah. So, I think sometimes you may have like a high utilizer of level 5s, for instance, but the patient data actually shows you a high age range, for example, can impact the level of service that you're providing. So ensuring that you understand the background of your data and why your data might be different from that external data will help you determine whether it may be appropriate or not. So it's not always wrong just because it is not matching that external data, but making sure you can reconcile that, right? And if you can't, looking into that further is wise.
Right. And that tees us up for some things we'll talk about shortly. So that was perfect. So let's dive in more to the data. So the data request component of your audit is really going to set the stage. So take your time on this step. When you get the data from your analyst or whomever, take your time to review. Our advice when requesting the data is to try as best you can to just obtain all the parameters that you're going to need if providing refunds on the back end. And you can reference the Medicare refund form for those parameters. Then once you have your data set, you'll want to carefully analyze and clean. And again, we want to take our time here because it can have that ripple effect if anything goes wrong at this point. So confirm the type of file received, verify what each column is indicating, make sure you understand what each column is and what it's not. Start to vet what can be removed, such as secondary payers and so on, as the slide describes. Now, some practice management systems are going to have more robust data than others. That's fine, work with what you have. But the key here is to know what you're doing with the data. So if you're unsure of anything at this point, you really want to confirm before proceeding. Continuing to vet your data, make sure it's not missing anything that would be vital to your audit. And this list here are some items that we commonly see missing when we request data, and we go back and request a reset on that. Then you want to validate your data. So do a quality check of the cleaning to make sure essentially nothing went sideways as you were removing things. And this second bullet here is a great example. Does the data make sense? And does it align with what you expected to see? So using that level 5 example that Valerie said, if you're vetting a provider who you know bills a high volume of level 5s, then your clean data should have that high volume of level 5s before you go to sample. If it doesn't, then you might need to rerun something or confirm that the data you had before was valid. Check your date range as well. We see mistakes often here if the report was run by payment posting date versus data service. That can throw off your date range very quickly. And then again, similar to the level 5 example, just vet your data against analytics from other systems such as the E&M bell curves.
And Kimberly, to your point, sometimes the data won't reflect what you thought it would be because the interviews reveal a perception, not a reality, right? So it may feel like something is happening on a regular basis because you feel like you see it on a regular basis. But when we look at the data, it actually isn't happening very often. So it doesn't necessarily mean the data is wrong. We just need to actually work through the process to determine what's right.
Right. It's a great point. Now, as you're going through the process of analyzing and cleaning, what you want to ensure is that the process or methodology is being documented. And we've summarized this in 6 boxes here. I do want to draw attention to number 3, the removal of non-applicable data. Remove what you don't need, but try to keep track of what that was. So in our analysis, we actually pull this into a separate tab versus just deleting it completely, so that if at any time we're questioning something in our final data, we can actually refer back to what was removed. And we note here that the best practice is to show the waterfall of claims. So for example, started with 10,000 claim lines, removed 500 for duplicates, 800 unpaid, and I'm left with a clean universe of 8,700 to work with. So that's a rough example. Box 5 here addresses sorting. You want to make sure that your data is not sorted in a way that can create unintentional bias, such as sorting by name or data service. And what this does is it can actually cluster certain claims together. And then that in turn affects the random nature of your audit when you go to sample. And then box 6, sorry, go ahead.
Sorry, just to jump in for number 1, that's the purpose of number 1, because the name that you have on the file and the parameters that you have on that original file will tell you how to pull it from the start, right? So when somebody comes back and looks for that same file, they should be able to pull the same file that you pulled, again, 2 years ago, so that they can come up with the same result that you did. So working through all of these steps are really critical.
Right. And then in box 6, where we're going to rationalize your final selection criteria, this really becomes the core of your methodology. Unlike box 3, this isn't just about removing unnecessary data. This is where you're going to document your intentional decisions that then defined your audit population. So this is where you might document that you're going to only view new patient office visits, or isolate to a certain provider, or focus on E&Ms with modifier 25, and so on. So then you document those specific steps taken to narrow down that data and ultimately select your sample. So Valerie, we've talked about this a lot too. This is a lot of effort. It really is. Why is this process so important?
Right. So, if you're doing routine reviews and you're doing 10 chart audits per provider, while you need to have some kind of regular, rhythm of what you're doing and capture documentation of what you're doing, this level of documentation is probably not as necessary. It's when you go to a second step and you're saying, okay, now we have a potential problem. Now we're really looking and investigating it. Having all of this documentation is necessary in order to duplicate the review again. And what you'll see here in a little bit as we get into the statistics, you have to be able to replicate the review in order to support that it was a correct, accurate review. So this allows you to potentially, replicate that review in the end by taking all of these steps.
So sampling, this is your next layer. And this is also going to vary a little bit depending on whether you're doing your probe audit or a statistically valid audit, which we refer to as SVRS. And I'll caveat here, just like Valerie just did, not every audit is going to be a probe or an SVRS. Most of the audits you do are just those basic routine checking in, monitoring your teams, et cetera. And we see those all the time. It's when, like Valerie said, when there's an issue or concern, that's when you usually move on to a probe. And really, probe audits are learning tools. So from a compliance standpoint, probes are about understanding whether an issue is isolated or systemic. And then depending on those results, we determine if we have a need for an SVRS. And then we've listed a few example categories here of how these reviews can be structured. So a probe audit, as the name suggests, is a small preliminary review that is not statistically valid, but it does help you get a quick sense of potential risks or problem areas. It can be, and often is, deliberately targeted or cherry-picked because you want to look at risk areas rather than representing the whole population. And so as we state here, the goal is really to avoid spending time on claims that are too subjective or too low volume. And then based on what you find in that preliminary review, you can then refine and confirm your correct universe of claims for that future expanded audit. And as we state here in the last bullet, the probe is ultimately intended to teach you where issues actually exist or where they don't before you commit to a full formal audit. So again, our goal is to be narrowly targeted, which helps decrease scope creep and the mistake of overstating dollars. And what we mean with overstating dollars is if you look at too many variations of claims in a probe audit, you might find errors in a few high dollar claims and walk away thinking that your organization has a much bigger financial problem than it actually does. So instead, you want to isolate so that other items aren't affecting your analysis. When defining the universe, you want to intentionally focus, again, as Valerie mentioned before, on specific services, providers, codes, relevant timeframes, payers, et cetera. And then some additional tips and risks. You want to confirm that you have a high and consistent error rate before expanding to that formal statistical audit. We do have older guidance that relied on a 50% error rate threshold, but more accurate decision points are typically 70 to 90, and that will all be discussed with the statistician as you work through that statistical validity. And then for meaningful interpretation, a probe usually needs to be 30 to 50 sampling units to really provide that solid preliminary indication of risk. So Valerie, any other thoughts on probe audits before I move on?
Yeah, I think to your point, this is to learn about the data, right? So you saw the data, it told you one story. Now you're looking at the records and getting a better story on what's really going on and assessing that risk and how how bad is it, right? How, are there really errors in this data, or is it just a perception? Is it perceived versus reality? But to get to the statistical side, we have to start getting a higher error rate in order to make it, in order to do the study. And because that's the way statistics works, we can deal with it if it is a lower error rate, but that's really what we're looking for, is those high error rates. But you're going to have internal decisions made around what those error rate thresholds are, and we'll talk about that in a minute as well.
So now you've sampled, and it's time to jump into your record. So the overall message of this slide is really to just stick to your scope. During documentation audits, you want to focus on that defined unit of measure, or in other words, what you're supposed to be reviewing. You can take note of other observations, but you want to keep them separate so that your review findings don't end up reflecting errors that aren't relevant to the reason you were performing that review. As we know, it's not uncommon for audits to reveal other things that you weren't looking for. We've all been there, but you just want to take note of those and then create a plan to address those later, at a later date. You'll also want to capture both a claims error rate, which is your accuracy of the sampling unit. So essentially, was the code right or wrong, or whatever you were looking for. And then a financial error rate, which is going to show your dollar variance based on the errors. And we'll get into those in just a little bit. EHR use. We wanted to comment on this as it surprisingly can impact your audit more than you think, both from a logistics standpoint and an operational standpoint. So logistically, make sure that you can find what you need in the EHR. It sounds simple, but while most documents should be in there, sometimes you're going to audit for services that are in a separate system. They might be housed in the hospital's EHR, maybe a third-party vendor system, et cetera. So you really want to make sure that there's a plan in place to obtain those records. This is also helpful when you have any external payer audits. You don't want to have any delays in those since the clock is ticking. So you want to make sure you know where records are housed that you're being asked to look for. From a process or operational standpoint, the way a practice or organization uses an EHR can actually be very telling in an audit. And as Valerie mentioned, it can be the root cause. When you're trying to identify that root cause of the issue, sometimes your EHR is it. So it might be inaccurate templates, outdated billing rules, or a charge master. And so you just want to consider that as part of your audit and be vetting that as you're working through it. Valerie, from your experience, when errors show up, how often is it a system or workflow issue like this versus individual behavior?
I would say it's a little bit of a question of chicken versus the egg scenario a little bit, because sometimes the system creates behavior and sometimes the behavior creates, is like it works against itself because of the system itself. The EHRs were built around a structure. A lot of it was built around the 97 guidelines, the E&M guidelines. So a lot of our templates, our documentation templates, were structured in a way that don't necessarily make sense, or don't run a logic cycle that a physician's thinking through. So they're trying to fit things into a place where it doesn't necessarily run in through their same mindset. So sometimes that can create issues. Now add in AI and AI scribing and all of those other things that we're going to be running into in the future. And we're going to have additional layers of where the problem is starting, right? Where that root cause is coming from. Because now we're going to have, somewhat like a dictation in the record, and maybe coming from different areas, and there may be background documentation that we may even need to look at as well. So I would say that it really depends on the provider and the system and how they're utilizing it, but I think the EHRs tend to be the root, even though it may be actually a provider. It looks like a provider problem, but the EHR may be exacerbating the problem, if you will.
Yeah, thank you. For time's sake, I'm just going to comment on this slide briefly, but this is an example list of items to confirm while you audit as applicable. Again, sticking to your scope, but just wanted to have some of these as a reminder, and be sure those that are performing your audit have been given the information of what they're specifically looking for, that specific criteria, to avoid any misunderstanding there. Lastly, you want to ensure your audit spreadsheet has all the appropriate information to capture your findings. So you'll want to show, of course, what was billed on the claim versus what was determined to be supported in the audit, and if found an error, that you have the reason behind that. As you document errors, it's really important to use consistent language to avoid any confusion. Others are going to look at your reports and your results, and so you want to just keep the error comments consistent so that they can see that those were all in the same bucket. You want to include your payments in order to calculate your financial error rates. And then you want to verbally communicate to your compliance officer or other leadership, and be sure any written documents are marked as a draft copy until approved. As you communicate to higher leadership, it's important, again, to stick to your scope, stick to what the relevant findings were, and what's the error rate telling you. So what do your results mean? And do bad results always mean that you have a problem? And the answer is no. So let's first confirm that that we have the claims error rate and financial error rate. So a high claims error rate does not always equal a high financial error rate, and vice versa, because the quantity of errors and how those are counted is not directly correlated to the dollar variance. So for example, going back to those high dollar surgical reviews, you can have 1 or 2 errors on a high dollar surgical claims review that's going to quickly increase your financial error rate. But if you only have a couple errors, your claims error rate is likely going to be low. Or sometimes you have to consider that it's a net. So if you have overcoding and undercoding in an E&M review, your claims error rate might be high because both of those were counting as errors against the providers. But your financial error rate might be low because those two are sort of going to cancel each other out. So it's important to understand when you're looking at your final numbers, what do they mean? What's the why behind them? How did they get calculated, et cetera? And sometimes what you'll find is you might want to exclude undercoded errors from the financial error rate and solely focus on overcoding if you know you're going to move towards refunds, et cetera. Next, determine the concentration of errors in the universe. So were they isolated to a specific provider, a specific time period, et cetera? You don't want to immediately assume that everything is systemic just because it showed up in the results. Then you want to compare your sample and errors to your universe of claims. So that universe is the clean data that you sampled from. And this will help show if your findings are statistically valid, but representative. So for example, say you did a review on E&M services and found the majority of your level 5 visits were incorrect. You might be shocked. But when reviewing your universe, you find that level 5 E&M services only account for 1% of your E&M volume. So you have an issue to be addressed, but it's on a much smaller scale than what the review portrayed. And this comparison here is one of the most important steps that we take in our reviews at PYA, because without that context, it's really hard to determine the true impact of the results and the meaning behind the numbers. Next, how subjective are the results? So some audits are going to rely heavily on judgment. Think medical necessity, peer review, even E&M complexity, while others are purely objective, missing modifiers, incorrect billing provider, et cetera. And then lastly, what operational processes are associated with the error? Going back to our talks about the EHR. Sometimes issues are going to be quick and simple fixes, like what we discussed. And so, those might be easier than others. And then also it's important to identify if it is operational, because you want to make sure that you're focusing the improvement in the right place. You don't want to do provider education if it's an operational issue. So we've covered a lot of ground so far. I think we've laid a good foundation. Valerie, take us into the statistics.
Yes, so let me actually advance too fast. So we're moving from the probe and thinking through potential next steps. Before we actually move into the expanded audit, we want to make sure we address the probe itself. So if you have any overpayments, obviously if you're moving to expanded, you do. Within that probe, you want to refund the probe audit within 60 days so that you're meeting the 60-day rule for those identified payments, because you're going to remove those probe claims from your next sampling. So as we move into that expanded audit, we can utilize RATstats, which is a software that the government allows you to use. It's available for free out on their website, and you can download it and you can make sure that you're utilizing that or a similar program. Most statisticians utilize other programs outside of RATstats. Some of them do leverage RATstats as well. But just because you use RATstats but just because you put all the numbers in RATstats, it doesn't mean it's giving you an accurate number. And knowing how to decipher that it's giving you an accurate number or not is really key. So having the right teammates involved in the review in order to make sure that you're following everything that you need to is crucial to not overpaying the government. It is possible to overpay the government. If you were overpaid, but you were not overpaid by that much that your result reveals, then you would be overpaying the government. So it's important to be fair, right? We want to make sure that what you're due, and what the governments do, they're due, and that we make sure that everything is right. We have to have that rate of occurrence. We have to have an actual error rate in order to get to an expanded audit. So that's where that probe comes into play. We're getting a rate of occurrence, which is the error rate within that review. Depending on which type of review you do, will result in the error rate you're using, whether it's the claims error rate or the financial error rate. It's dependent on the type of the review that you're doing. So let's talk about statistics. I want to walk through a bit of the actual manual guidance related to the statistical sampling from CMS's perspective so that you can see what their thought process is. But one of the things to note in the final rule, in the 60-day rule, and it was originally in the preamble of the 60-day rule when it originally came out, there's this statement about, after finding a single overpaid claim, we believe it is appropriate to inquire further to determine whether there are more overpayments on the same issue before reporting and returning the single overpaid claim. And when this statement was originally put out there, a lot of people feared that any type of overpayment is something that we have to do a statistical sample on. And if if you're doing routine reviews and auditing on a regular basis, there's just no physical time to do all of that. So you must prioritize everything that you're doing so that you're focused on those highest error rates and those highest concerns, and really focusing in on that and utilizing the resources that you have and the budgets that you have to address those. But a healthy compliance program is routinely auditing and routinely identifying where the highest risk is and addressing it. Sampling and extrapolation methodology must be explained in disclosure, as we mentioned. This part of it is why we have to document what's going on throughout the process in order to explain how we got here. What is the methodology that we use to get here? So the resources of guidance are included in the OIG self-disclosure protocol and in the CMS Program Integrity Manual, which I'll call the MPIM, the Medicare Program Integrity Manual. We often call it the MPIM. So in Chapter 8, 8.4, Section 8.4 is where we get this guidance. The OIG does not have to follow CMS's guidance. CMS's guidance for the Program Integrity Manual is for their contractors, not for the OIG. The OIG oversees CMS, right? So they're making sure that CMS is doing right. CMS is then making sure that the contractors are doing right, and it rolls from there. So CMS is providing guidance to the contractors. this guidance gives us kind of a feel of instruction of what we should be doing as the provider. So that is why we leverage this documentation in order to confirm that. And then your outside statistical or internal statistical expert is really key to leverage as well. Ensuring that they have knowledge about healthcare is also important, because it's one thing to do statistical assessments on other things. It's another thing to do it on claims, and claims are their own animal and can have complexities that are outside of logic. And so understanding that and being able to navigate that is, and it's based on experience. So having an experienced healthcare statistician is important. So let's talk a little bit about parts of the manual. One of the first things it talks about is, as Kimberly mentioned, having a high and sustained error rate. And then from that, doing education. And if that education does not actually result in a change, then moving with forward with a statistical assessment. But what we find is that we're kind of in between the statement that I just mentioned, where it says we've got one claim and now we need to determine if there's a problem or not, to having a high and sustained error rate and doing education and then determining if we still have a problem or not. Somewhere in between there is where the truth and reality is. And that's the complexity of dealing with this on a routine basis, is that is the range. So when you're working on a review and you're doing your diligence for this review and making sure that you're getting everything right, it's a matter of having the right policies in place, saying this is how we're going to do this on a routine basis. These are our thresholds for when we're going to take it to the next step. This is kind of our understanding of our risk tolerance and addressing that through those policies and procedures, so that your internal teams understand where to go and what to do and when to escalate it. But that's a challenge, right? There's a wide variety and variation on how you would interpret this. So getting the internal teams to agree on where that is important. So conducting the sampling and working through the sampling process, it describes identifying the provider or supplier. That's your defining that universe, defining that sampling frame, identifying the period to be reviewed, making sure you have a start time and a stop time. When we're talking about the 60-day rule, we're usually looking back 6 years, or we're determining whether something started and stopped within a certain time period retrospectively, because you wouldn't audit 6 years if the problem didn't go back 6 years. So you're learning what that is and then determining that. Defining that universe, you're saying exactly what that target population is. Defining the sampling unit, that may be a claim line, that may be a claim, that may be a patient. That could be a whole other unit. So we have to define that, because that is then how you sample. So if you have 100 claims, but you only have 10 patients, then you only have 10 patients to sample from. And that random sample would be within that 10 patients. So obviously you wouldn't need to do a statistical sample if you only had 10 patients, because then you could review those 10 patients and do your review, complete your review. Effectively, anything under 200, you probably just want to go ahead and do a 100% review. We'll talk about that in a minute as well. But then this blue part here, the statistician should state the assumptions being made about the distribution and explain the sampling methodology selected as a result of that distribution. Again, it's talking about describing the methodology all the way through the process. So if these are areas where you would not have the skill set to do this, you want to outsource that or identify people that can do that internally with your team, so that you can ensure that you're following these steps. Then performing the appropriate assessment to determine what the sample size is. So you work through RAT-STATs to say, okay, here was our probe error rate. We're determining which our confidence interval and our precision is going to be. You're including that in that, and it's going to tell you what sample size to do based on those error rates. So then you take that sample size and make sure you have, your that number 6 is making sure you have that sample frame defined. It's kind of the step prior to the other. So making sure you have that sampling frame defined, then you're sampling through that, and you have that sample size that you're sampling through that. So you're getting a random sample of all of that. Examining each of the sampling units and determining if there's an overpayment or underpayment. So then that's your documentation review. And then this blue part here at the end, the contractor shall provide complete and clear documentation sufficient to explain the actions taken in the step and to replicate, if needed, the statistical sampling. This is where that replication comes into play. So we have to be able to replicate this review. So knowing which report you pulled, what the parameters were, what the date range was, what codes you're reviewing, what providers you're reviewing, if you're reviewing all the claims from those providers or just a certain claims, and whether there's a break off and why you're taking those off and that kind of thing. All of that matters and has to be documented. One of the things here that I'll note is that it's saying that basically no matter which method you use, you have to result in a probability sample. Now that is actually not possible in every case. When you have data that is not possible to knowingly sample, which means you have a data set and you think you have Medicare data and you start sampling that data in your probe and you realize there's actually other payers in this data, even though my data set says Medicare, it's actually other payers. So now you don't have known data in that sample, but that's the best data that you can get. You're not going to end up with a probability sample, but there are ways to work around that to show a good faith investigation and review as we get back to that first slide, making sure we're doing the best we can with what we have. So there's going to be a lot to explain if that occurs. So we have to be able to explain it if we're not getting a probability sample. So we're going to talk about what some of those pieces are that are required for a probability sample. So it must be possible. You'll see in that second bullet, it must be possible in principle to enumerate the set of distinct samples that the procedure is capable of selecting if applied to the target universe. So essentially, you have to say, I can select the sample within my sample, or the sample that I'm selecting is going to be a representation of the larger picture, if you will. So I've got a small picture here, and it's absolutely representative of that larger picture. Not absolutely. We have a confidence interval, so we're saying we're about 90% sure. So then moving on, you have to also, in this blue here, you have to make sure that everything is greater than 0, which means you have to have paid claims. So looking for your paid claims, removing anything that is 0 or less than 0. So if you have negatives, assuming that your payments are positives within your data, which you want to confirm that, right? You don't want to assume that your payments are positives in your data. If they are negatives, you may actually want to flip them just so it's easier to recognize. But you want to identify where the payments are. So you're looking for an overpayment, you have to have a payment. So remove those 0 and under payments. So this blue here again, some procedures lead to higher precision, smaller confidence intervals than other methods. So what this is saying here, we're talking about a contractor doing all of the steps that this has described, that the MPIM has described, and it's gone through all of those steps and it said, okay, here's the result. What this is saying is basically if you've done all of these steps, then no one can refute that something is not statistically valid. Now, we would say that there's going to be holes in everything. There's going to be opportunities to determine whether something is truly statistically valid. But usually where we see this is utilizing the RATstats tool, and it is telling you it has certain abilities like alerts that it has now that will tell you that it's actually a lower confidence interval than what you selected. And so understanding what that looks like and what it means then enables us to determine whether it really is as accurate as it's saying it is. But if it is, then it's saying here that you can't refute it. That's a challenge to overcome, but there are ways to address that, especially if we feel like the error in itself were the errors that were found in the documentation were not actually errors. If we can remove those, then we start removing the sampling method altogether. So let's revisit. So probability requires independent observations, meaning we can't have dependency within the data. So if we have multiple dates of service for a patient, what we typically do are saying, okay, we're going to sort all of the patients, not by name, but there's some random generation ways that you can sort patients, and then get all of those patients in a list, and then select the patients that you're going to review, and then select their, for example, middle date of service within that date range that you're looking at. That allows you to have those independent observations on those patients where there may be dependencies if you're looking at the same patient across a period of time. Normally distributed is describing a bell curve. So we're looking for a nice bell curve. That's often hard to get to. So we have to work through some methodologies in order to address that if it's not normally distributed. Continuous data, this is where we get into stratification issues. If we have claims, we're talking about dollars that are from zero to, say $100,000. If we have claims within that, but now we're defining something across strata that have overlapping payments within that data. So we have $100 here, $100 in this strata, and $100 in this strata. We're actually overlapping those strata and not having that continuous data across those strata. And now we've created a problem within the review. Back to the non-zero items, we have to make sure we have paid claims. We should be representative of, the sample should be representative of the whole. So oftentimes the way we'll test that is to say, what is the percentage of the claims, the types of claims that we have, and is it the same kind of percentage as we have from the sample all the way into the total frame? And then making sure we're using that random selection process within RATstats or another tool so that we ultimately have a seed number. You produce a seed number within RATstats or in another tool in order to show the frequency at which it's pulling those samples. And having that seed number allows you then to replicate it in the future. So make sure you're keeping all of your documentation from RATstats as well. So again, we have to have a known overpayment. That's when we get that incidence of error in the probe. We're defining the universe. We have to have that to be numerical, not verbal. So we can't just talk about departments and talk about providers and things like that. We have to make sure that we are looking at the data from a true data perspective, the frequencies of the services, the amount of payment for those services, and how that looks. The limiting criteria, we're determining who we're looking at, what we're looking at, the time period, and how the overpayment will be measured, defining that frame, the sampling unit, and determining whether we're doing a simple or stratified sample. Again, these are areas, this last part is an area where you definitely want to make sure if you need to segregate your data into different groupings that are not going to be simply separate reviews altogether, stratification requires real knowledge around how to do that. So let's talk quickly about attribute versus variable sampling. When we're looking at different types of sampling, attribute is where we're saying yes or no to a question. So we're saying, was the claim accurate or not accurate? This is usually where we're having a lot of difficulty within the data. We really need something that makes it more simple. So then we say, let's come up with a yes or no question and come up with a hypothesis that allows us to answer a yes or no question. So then we're doing attribute sampling. The variable sampling is where we're dealing with the dollars, and we have good normally distributed data, and then we can address that from a variable sampling. These are two terms that you'll see in RATstats, so you want to make sure you're selecting the right sampling method and then ultimately the right appraisal method on the back end. You'll have that rate of occurrence. Say you have a 60% error rate, claims error rate, but then you have a 30% financial error rate. Which rate of occurrence do you need to use? That will be dependent on which type of sampling method that you're using. So understanding that is key. Oftentimes we're using a confidence level of 90% and a precision level of 10%. Again, these are things that you can include in RAT stats in order to determine that sample size, and then ultimately the appraisal at the end. And then your frame size will be something you'll have to know as well, which is the number of units that you have. It's not the number of claim lines if that's not the unit that you've defined it to be, right? So you have to keep that definition of your unit throughout the process in order to have the right numbers go into RAT stats. So then RAT stats determines the sample size determination for you. So when we move past the review, so we've already talked about, risks that you can have in the review itself. And now we're at the extrapolation phase. We've looked at it. We've said, okay, we still have a high error rate in this full sample review and this expanded review. Now we need to truly address it. We work through either the attribute or the variable appraisal. We're confirming accuracy within that. Again, I said that there's some alerts that are within the reporting with RAT stats that you want to confirm that it's not saying that your confidence interval is different than what you intended it to be. And then once you have determined what that error rate is that you're going to apply, or the dollar amount that you're going to determine, then you can apply that same effective error rate to other payers. We usually do this with Medicaid and other payers as well to ensure that we're covering any other government payers that we feel like should be addressed. So then if no extrapolation is performed because you have a low error rate, for example, and you determine where that threshold is, then you need to refund those claims within 60 days at that point. So let's talk about the 60-day rule quickly. In 2025, we had a change from where we were back kind of 2010 to current. And because they defined the overpayment based, or the identification of an overpayment based on the knowledge standard which is in the False Claims Act. So now when you know that you have an overpayment, that is when you have identified an overpayment. That is kind of challenging, to really nail down, but you'll want to work through your external and internal legal counsel on how they're going to define that so that you know where your day one is, because that is really key. We still have a 6-year look back. There's no reference to credible evidence in this recent rule, and there are no ties to quantification. So let me show you how this really works. So historically, we have credible evidence. We have 180 days to work through an investigation and quantify the error. And then once we quantify that error, we have 60 days to refund. That was the historical way we looked at it. Now we start day one by identifying that we have a potential problem. We have a knowledge of an overpayment. Now we need to determine, is this systemic? So now we pause the day one and say, okay, now we're going to take 180 days in order to determine if we have a problem and quantify that. And then once we've quantified it within that 180 days, the 60-day clock starts again, and then you have to have that refunded within that 60 days. So it's a little bit different from before. It does cause a little bit of questioning of where you are in the process a little bit, but documenting where you are in the process and how you're going to address this is important, right? So making sure that you're all on the same page within your internal teams on how to address that is key. So corrective action, how do we go from here? What do we do once we've created a methodology report, we've reported to Medicare in regards to the overpayment, but now we need to address it on the back end. Really, we want to include our corrective action in our final report internally as well. So doing a root cause analysis, determining where the problem is, what processes and people and technology were impacting this issue and getting to that root cause and determining how to revise the process in order to keep it from happening again. Now, you may, during the middle of your review, stop payment so that you don't have that continue, right? You may want to go ahead and stop things before they continue so that you don't have this issue ongoing. And then as you get to the completion, then you're opening that back up and then determining, okay, what do we do from here? Implement internal controls. So you're defining where your internal controls may have failed and then or need to be improved and working through those corrective actions. Provide the appropriate staff training so that you are covering that, and then do your any follow-up audits. That you don't want to stop it there. You want to make sure you're making sure that all of the corrective actions are put into place and working, right? So it's not just a coding review at that point. You're looking at your operations, where the operations truly changed. Are they effective, and is it working all the way through the coding as well? So ensure that you're, as I mentioned, including that corrective action in the final report, and mentioning also the final report. Kimberly, you mentioned the draft, audit report, and then that final audit report is where you kind of say, okay, now we've got a final. This is what we're addressing from here. What we've found in historical reviews that have been done by the government is draft reports can be considered final if they're just left open as never finalized. So make sure you're getting to a final conclusion on these reviews so that your dates and your actions can be addressed based on your timing of your finalization. So make sure you communicate to your stakeholders regarding the results, regarding the, what the next steps are, and how you address the root cause analysis. And then make sure you're addressing any issues that are ongoing with your providers in a routine basis. So if you have providers that are consistently not meeting expectations within these reviews, then you want to have consistent disciplinary action across all providers, so there's no consideration of any favoritism. So just thinking in conclusion, this is not the only impact that these reviews have. So we have a review, we do an refund from an overpayment perspective, but there may be other things. The ripple effect of this is maybe physician compensation. What does this mean for physician cost compensation? What does this mean for our cost report within the facility side? Are there any facility side or pro-fee side actions that have to be addressed, based on the focus of our review? Are we implicating Stark or other federal statutes? And then making sure, again, that all stakeholders are understanding of how these errors might impact other areas. So thank you all for joining us today. We enjoyed speaking with you today and want to ensure that you have all the information that you need on this. So if you have any questions, please reach out and let us know. Jennifer?
Thanks to our presenters, Valerie and Kimberly. The slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions, or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.